about what to talk about, you know, hemothorax is a pretty common thing that we and you guys see. But, you know, I just wanted to give you a view of what happens really afterwards, what could happen afterwards, so you just have an idea of how to deal with those things. So I decided to talk not just about hemothorax, but focus on retained hemothorax. You know, we'll talk about what is retained hemothorax. Of course, does size matter? I'll let you know what that is. Antibiotics, should we use antibiotics prophylactically or therapeutically for thoracostomies? YATS, VATS, TPA, that also will become more clear later on what that is. And, you know, is there actual data? And of course, on treatment, what we do. So imagine, you know, you got somebody shot in the right chest. You have an opacity here, pretty clear-cut diagnosis of hemothorax. You place a chest tube. It kind of looks like this in the beginning and just lingers like that for a couple of days. So you start wondering, what is that opacity up there in the right chest, persistent opacity? Is it a contusion? It's conceivably could be a contusion. There's a bullet track that went through there. Is it a consolidation? Is this person developing a pneumonia? Also, very, very probable scenario. Or is this a retained hemothorax? So actually, you can't tell. You can't tell what that is purely based on the chest X-ray. So you will get a CAT scan, a non-contrast CAT scan of the chest, and it will show you, confirm your diagnosis of hemothorax, because on a CAT scan you can tell the difference between fluid, consolidation, atelectasis, or contusion. So this is, you see, it's low density fluid here. This is a retained hemothorax. So you get a CAT scan, you get your diagnosis of retained hemothorax. So we define this as an incompletely evacuated pleural space after tube thoracostomy, and we measure it. There's a volumetric measurements based on a CAT scan, because you want to try to estimate the amount of blood in the chest, and that will sort of guide you what to do, to watch it, to act on it, etc. So there is a formula. I forgot which paper it came out of, but it seems to be widely accepted, where D is the greatest depth of hemothorax, is this distance multiplied by craniocaudal length and multiplied by number of slices. So imagine it's more or less approximately a cylinder, you know, in your chest. So you get your volumetric measurement based on a CAT scan, and then you proceed. So what are the treatment options for retained hemothorax? Oh, also, I wanted to bring this up to sort of stress the importance of CAT scan in the diagnosis. This was a prospective evaluation of 700 patients who had tube thoracostomy for hemothorax, and they discovered 58 patients with persistent opacification on a chest X-ray, and they were confirmed by CAT scan. But they also saw that nearly 50% of X-rays were interpreted incorrectly by radiologists and surgeons, just stressing the importance of a CAT scan to make a diagnosis, because you really don't want to be acting on a consolidation and subjecting a patient either to another chest tube or another intervention, because it's not going to be helpful. So CAT scan is very important. So what about the antibiotics? We know that administration of preoperative antibiotics in elective surgery reduces chances of surgical site infections, and that's because you achieve a plasma level of antibiotics before you make the incision, therefore reducing incidence of wound infection. But what about the hemothorax? Because this is a procedure, we place a chest tube. Will antibiotics help reduce the incidence of infectious complications, such as pneumonia and empyema? So, you know, this has been looked at, and this is a practice management guideline from the Eastern Association for Surgery of Trauma. It was, they had one in '98, in 2000, and this was an updated version from 2012. So they looked at, without going too much detail, and there's also a lecture by itself, they looked at multiple publications, they looked at the data, and they concluded that they cannot make adequate recommendations at this time. Hopefully, maybe in 3 or 4 years we'll have an update. But if you think about it, the pleural space has already been violated, whether it's by bullet, fractured rib. So giving prophylactic antibiotics will not achieve a therapeutic level before the injury occurs. So it's very questionable whether they work at all. And they looked at, the reason they call it presumptive and not prophylactic is because you give it after the incision, or after the pleural cavity has been violated. So on one hand, you want to prevent the infectious complications. On the other hand, you want to prevent the proliferation of resistant organisms. So our practice, we generally give 1 dose of antibiotics in a trauma bay before we do a chest tube, and we do not continue. So this is their final recommendation: routine use of antibiotics to reduce the incidence of pneumonia and pneumonia. It's controversial. No recommendations can be made at this time. Very helpful. So does size matter? And this was addressed in this prospective analysis of 2 thoracostomies, and they looked at smaller size chest tubes, 28 French to 32, versus a big size, up to 40 French. This was from the West Coast, and they looked at, again, this was not randomized control trial, this was just an observational study, and they looked at the difference in complications, small chest tubes versus large chest tubes. You saw complications almost identical. Incidence of pneumonia and empyema very similar, as well as incidence of retained hemothorax, very similar with known. And they also looked at whether interventions after smaller versus larger chest tubes would be different, and they turn out to be the same. So the conclusion was size does not matter, despite what anybody else might say. Of course, people took it one step further and said, okay, this works. How about we put a 14 French pigtail? And there was some small studies that were very questionable. There's some swine model of using those 14 French catheters. So I'm pretty sure in the next few years we'll go even smaller. But for now, in place of regular sized chest tube, wouldn't matter either way. Oh, and also the pain scores, larger versus smaller, did not matter at all. They were all painful. It doesn't really matter, it seems like. So do whatever you want, essentially. So what's the treatment of retained hemothorax? One option, of course, do nothing. Great option. Do nothing. You do observation. And how good is observation? And this was looked at. This was a prospective observational trial, multi-center trial from AAST, and they just looked at how people manage retained hemothorax. So they had 328 patients, 100 of which they observed. And they had a pretty good success rate. 83 of those were successful. More than 83% success rate. So of those 83 successes, 80% had volumetric measurements of less than 300, 16 300 to 900, and 4% greater than 900. Of course, 18 patients required an intervention, and 7 underwent a thoracotomy. Only 2 patients underwent VATS. I mean, this is an older study, so they looked at way past. So VATS, thoracoscopy was not as prevalent at that point. And second chest of TPA and pigtail. So observation is pretty good, 83% success rate. And we'll talk about which patients are appropriate to observe. It seems, according to this study and others, that of course the smaller the pneumothorax by volume, the more successful you are in observing. And 300 was a number thrown out there as sort of a threshold to intervene or not intervene. So another intervention is second tube thoracostomy, and this was done very commonly in the past. You get a hemothorax, it's not evacuated, you just put a second chest tube and then a third chest tube. So this was done commonly. And if the problem with this is that when hemothorax is not evacuated, it's probably clotting. So no matter what you do, you put a chest tube into a clot, it's not going to evacuate it. It's going to stay there. So now you're subjecting a patient to unnecessary violation of the pleural space, unnecessary risk of infection. Remember, every intervention in the pleural cavity can lead to infection, pneumonia and empyema. So you have to really think twice before you do this. So is it good? How good is it, these second tube thoracostomy? This was looked at. This was probably one of the few, or maybe the only, randomized control trial where compared the thoracoscopic evacuation of retained hemothorax versus second tube thoracostomy. Very small though. It's only 39 patients, 24 in the second chest tube group and 15 in the VATS, video-assisted thoracoscopic surgery. So they compared them. Group 1 was second tube thoracostomy, Group 2 was VATS, and they looked at the duration of chest tube drainage. Of course, VATS, it's less chest tube drainage days. Hospital days were less in the VATS group. total hospital days was less in the VATS group, as well as the estimated cost. You know, it's kind of strange. You do a general anesthesia, do a significant operation, but it's still, the hospital cost is significantly less. And then they looked at the clinical outcomes. They compared group 1 and group 2. These were, of course, crossovers to either VATS or thoracotomy for group 1. And they looked at also drainage of chest tube days, total hospital days, estimated cost. All were less with group 1 and with additional procedures. So therefore, you know, the conclusion of the study was that VATS is a very useful modality. And probably second, tube thoracostomy should be abandoned. And that seems to be our practice, and I think practice pretty commonly across the country. So the third option of treatment is intrapleural thrombolysis, where you instill a TPA, tissue plasma management activator, into the pleural cavity in the hopes that it will dissolve the clot and evacuate the hemothorax. The problem with this, it just takes time to work. It takes a few days to work. So this also has been looked at in several studies. In this observational study, they looked at 25 patients who were treated with TPA, and pretty good success rate. 23 resolved their hemothorax, and really no hemorrhagic complications or adverse drug reactions. So this is a very probably useful modality in those who cannot tolerate the general anesthesia and VATS. So very, very useful. And then finally, VATS, video-assisted thoracic surgery for evacuation of hemothorax. We do that quite often these days. Very, very useful. And it's been looked at in multiple studies. In this particular one, was a retrospective one. We had 83 patients that underwent VATS, and they looked at those that had VATS before 5 days, earlier than 5 days, and later than 5 days, and they looked at the difference. And you see it is similar in age and injury severity score. Time to the operating room, 4 days here, 9 days here. Significantly less conversion to thoracotomy rate in the earlier group. Number of patients with multiple chest tubes significantly less, and somewhat less of infectious complications in the earlier group. Therefore, you know, generally we recommend doing early VATS. Definitely less than 5 days. We actually do it earlier. Try to do it earlier. If you have retained hemothorax on day 2 or 3, we just take them for thoracoscopy evacuation. And that also seems to be a common practice. So what is the best timing? This was also kind of looked at in this retrospective one. And they looked at the success rate as a function of days. And as you see here, the earlier you take them, the success probability goes up. The later the surgery, of course, the lower the success. So of course, the earlier the better. And then we'll go back to this AAST study when they looked at development of empyema, which is something that we're trying to avoid, pneumonia and empyema, because empyema would necessitate thoracotomy, decortication, and significant morbidity and maybe mortality. So they had a fairly high incidence of empyema, almost 27%, and they looked at the independent predictors of empyema. So they look at those independent variables, and risk fractures, high in severity score, and additional interventions were risk factors for empyema. So if you identify patients who have those variables, if you can predict the risk of empyema, you can act earlier, meaning you can take them to thoracoscopy way, way earlier to avoid this devastating complication. So the risk factors were also looked at in this particular study from 2008, and they had a very low incidence of empyema. I don't know why such a difference. 27% there, 3% here. Somebody's lying. And they looked at independent predictors of empyema. It was retained hemothorax was a predictor. Tube duration greater than 6 days. An ICU stay of greater than 2 days. Exploratory laparotomy, and presence of pulmonary contusion. All independent risk factors for empyema. So therefore, if you have a patient like that, if you can identify those at risk for empyema, you can act earlier to prevent that from happening. So this is essentially it. There's a couple of new things. I talked about YATS in a very cool name. It stands for Yankauer Assisted Evacuation of Pleural Cavity. And it basically as you put a chest tube in the trauma bay, you know, you hopefully under sterile conditions, you take a sterile yank hour and you just suction out the pleural cavity at the same time as you put a chest tube. So theoretically, that can increase your success rate of avoiding this retained hemothorax and evacuate the pleural space completely, but does it really work? Well, we don't know yet. There's going to be a presentation during the 2016 East Conference about this, and they did a small prospective study in Memphis, and they had 102 patients, which they compared to historical controls, and they used yank hour suction in them. And they saw no difference in the retained hemothorax and empyema. They did see better, it evacuated the pneumothorax better than the regular chest tube. So there's going to be a large multi-center trial sponsored by East in the next few years, and hopefully in the next 3 years, in about 3 years, we'll have an answer. We hope to participate in this trial. We signed up, so we're just waiting for our RFPs, and likely will start sometime next year. So in conclusion, VATS is a very useful modality. I mean, that data seems to support it, early VATS. We need to identify patients at risk for empyema so we can act earlier, as we looked at volume of the hemothorax, injury severity score, rib fractures, put those at risk. And also keep in mind, any additional intervention, any violation of the pleural space can lead to infectious complications. So you have to really weigh risks and benefits before you act. And YATS is coming. Thank you. I'll take it.
Questions?
I have a question.
Yes.
So, in terms of downstairs in the ER when a chest tube is going in, when you know there's a hemothorax that you're trying to intervene on, are there certain techniques that can be employed to reduce retained hemothorax? Should we let it bleed out as much as possible?
Should I stick a yank hour?
Should we stick a yank out?
You know, just, I don't have an answer. I mean, just be sterile. That's very important, because the empyema is devastating. So unless, you know, somebody's dying, and we do thoracotomies with our bare hands sometimes, but keep sterile. If you have time, don't rush. Prep and drape, as you imagine you're in the operating room, sterile gloves. And as far as any other techniques, just proper technique, I think, would help. Try to put it posteriorly into the apex if you can. Yank hour, yeah, we'll get an answer, I guess, at some point, whether it actually helps or not. Theoretically, it sounds great. But again, if it's clotted at the time of the chest tube placements, other than taking sterile water and irrigating the pleural cavity with sterile water, but you sort of don't know at that time whether it's clotted or not. You wouldn't know until the next day, probably. So, no.
Does stuff like milking the tube help, or?
I'm not sure if it does. Does it? I doubt it. Yes, Dr. Ruditsky.
Any data about peri-procedural antibiotics and impact on infection?
Yes, there is data. Actually, we have no answer for that. So it's been looked at. In 2012, there were East trauma guidelines, but there's no recommendation can be made. There was some data, conflicting data, when they looked at all the papers. One paper said yes, it actually reduces the incidence, just pneumonia, not empyema. And others said, actually no, it only does, it leads to resistance, organism resistance. And they looked at mostly 24-hour antibiotics after the tube thoracostomy. Yes?
Has anyone ever tried to get oral antibiotics at the time chest tube goes in?
I don't think so. It's a good idea.
Just leave it in there, might help.
Yeah. I don't think anybody would say that. I haven't seen it. But that's a good idea. Maybe we should do it. Now, which antibiotics can we do that with, I wonder? Any antibiotics?
Ones that don't need first pass.
Supposed to grab
conversion
positive,
to their
bank doesn't get it warm.
Yeah.
One that first pass.
Anything else? Yes.
I'm sorry if you explained it or not, but I'm kind of trying to picture, how does the yank power work? Do you stick it through the chest tube?
No, I just stick it in the
Kelly
chest.
in
At the
hole.
same time?
Right, yeah. Like, yes, you make your incision, you get into a pleural cavity. You know, you have your finger there, as you usually do, you sweep. So before the chest, you just put a yank hour and just sucks things out.
And if you can get most of it then, do you need put the chest tube in?
You should, yeah. You should put a chest tube, because, you know, if you have a lung laceration, if you have ongoing leak, ongoing bleeding, you should put a chest tube to evacuate that.
So now, here's the question, if you've gotten into trauma, do you really want to be sucking out as much blood as possible?
I don't know. Maybe not. Maybe you stick it into, you know, if you have a cardiac injury, you stick it there, and you start sucking and sucking. Obviously, a patient like that will be in shock, so we'll be quick. We'll forget about a yank tower for that moment. Thank you. Yes?
I think it's our general practice to give antibiotics, as you mentioned, for penetrating trauma. It sounds like from what you're saying, even with lung trauma, like gas pneumothorax and have the chest tube placed, you guys would want us to give
Yes.
antibiotics for that. Okay.
Yeah, absolutely. I actually came across a study from British Journal of Surgery from last year, where they just looked at the blunt trauma. I think it seemed to be better to give antibiotics, but they look specifically at blunt trauma only.
Okay.
Thank you.
Thank you.